Whirling. Okay, so hi guys, we're just checking that we've gone live, which I think we have. I've got my phone here, so if anybody's watching, if you could just ping up a comment and say hi, that'd be really helpful. And then we can see that you're there. Okay. So yeah, we're on. So hi guys, let me just, you know what a technophobe I am. I'm getting myself in my ear. So I'll turn myself off just for a minute. So yeah, hi everybody. Welcome to February's Rider Clinic. As you know, this month we are joined by the wonderful Maeve Sheridan, who is a fabulous chartered physiotherapist for both humans and horses, and works with both. And we both, as myself as a trauma doctor and Maeve as a physiotherapist, get a lot of questions around back pain. So we felt rather than keep answering kind of questions on different lives, that we'd actually come on and just do an hour about back pain and see what we can get covered. Now, it's a huge topic, guys, okay? So bear with us. What we're going to do is we're going to run through sort of the bits and pieces that we think are important from our practice and warnings to you. And then we're going to leave a reasonable amount of time at the end for questions. But if you don't get a chance to get your question answered, we do go back after a live and we have a look at questions, and you can always DM us if necessary. So just to start off, because I know we've got a lot of new followers. Well, I have, and I know we've got viewing about 140 people at the moment. So my name's Dr. Diane Fisher. I am a major trauma and emergency medicine consultant from the University Hospital of North Staffordshire, and I'm an equestrian. So I set up my page to sort of deal with the boundary that there is between medicine and equestrians, and we're far too brave, and we have issues where we miss injuries, or things just get discovered a bit later. So it's about educating ourselves. And then I've met Maeve. I met Maeve because I bought her Activate Your Seat program. I'm actually grading for paradressage, and I needed something that specifically would help me get stronger. And as soon as I saw Maeve's posts about her bungee, and she mentioned psoas, having operated on numerous people and looked in the back of the abdominal cavity, everything she said made sense. So I bought the bungee, started the program, completely transformed my body, and we became friends. So then I'm going to hand you over to Maeve so that she can introduce herself, and then we will crack on.
So I'm Maeve Sheridan. I'm a chartered physiotherapist. I have been doing this job for about 20 years. I also am a veterinary physiotherapist, so I now just treat horses and horse riders. I've treated horse riders for years and years and years, and similar problems time and time again with horse riders, which is why I designed this exercise program with the bungee. But I also see a lot of back pain and have dealt with a lot of back pain over my career. And so, yeah, so that's what we're going to talk about tonight.
Yeah, brilliant. So I think we've obviously talked about what we think we need to cover prior, but I think we're just going to kick off with that initial point where you potentially will come and see me. So the type of things that I would see as a trauma consultant, obviously there are fractures, so fractures of the spine, etc. And then I would see people that come in maybe that have got a sort of an acute back pain or a strain or something that's happened. And I see them very quickly because the first port of call is, ow, that really hurts, or I've fallen off and this really hurts. I need some help. And it's a pain that usually lets you know that there's something that's not quite right. So we'd sort of talked about between ourselves, we thought it'd be quite helpful for you to understand a little bit around the anatomy of the spine. So I haven't got my Martha out, but Maeve's got a Martha substitute. So Maeve's
a bit of a Martha.
A bit of a one. She's going to have a little bit of a chat around the anatomy of the spine, just so that everything we then talk about makes sense to you. So go for it, Maeve. Show us those bones.
So this is your spine. And the bit that we're going to talk about mostly tonight is the lower back. So your lumbar vertebra mainly. And so we've got 5 lumbar vertebrae, and in between each vertebra you have these discs. And so they're designed to allow your spine to move and to absorb that movement. And they're pretty strong structures. So people get a bit of fear around discs and think that they're quite vulnerable. They're actually pretty tough. And then the spine is designed itself to protect your spinal cord, which runs down the back. So it runs from your brain down the back of your spine, and then from that come all the nerves that talk to the rest of your body. And so in particular for the lumbar area, it's all the nerves that feed this lower half of your body and into your legs, and then all of this big nerve bundle that we're going to talk about a bit now with Diane, that hangs down in here, called your cauda equina, which is like your horse's tail. And so it's a big bundle of about 20 nerves that feed the legs and feed your bladder and your bile, and basically that whole area. And then obviously we have this area here, this is your ilium, this is your sacrum. So this is your sacroiliac joints that we'll talk a bit about as well. And this is your sacrum down into your coccyx, which is your tailbone, which can sometimes get injured with riders as well. And then up from that come your hips.
Yeah. So that's it kind of in a nutshell, isn't it? And for the guys that follow me and follow Maeve, because we quite regularly talk about anatomy on our pages when we're explaining things to you, we've looked at sort of C-spine, T-spine, but, you know, we are really going to concentrate on this lumbar spine area, which is the most common area that people get sort of acute back pain, chronic back pain, and it's not unusual to get fractures. So from my perspective, if I'm seeing somebody from a trauma perspective and we're talking about the lower back, I don't know if you can just point out, Maeve, but there's a couple of places that are particularly vulnerable. And one of the places that is very vulnerable is sort of T12, L1. So the difference between the sort of thoracic spine that ends, you see, that kind of like ends down here, and the lumbar spine is quite a kind of vulnerable area for when you fall, because of, we call it flexion and extension. So when you move forward very quickly or back very quickly, then you can have problems around that area. If you've had, if you've come off your horse or whatever the accident is, and then you are, you know, got really severe back pain, from my perspective, from a pre-hospital, you need to try and keep that person as still as possible, ideally in the position that they've landed in, as long as that is safe for them to stay in that position. Now, it's very difficult when this horse is, you know, then loose and somebody may try and move, etc. As I've said in previous clinics, and I sort of keep banging on and on and on about it, all of the trauma stuff starts with A. So you need to make sure that that person, that their airway is open and that they can breathe okay, and that obviously they've got a pulse and all the other things. So you don't need to do anything with that. So we're going to park that to one side and say that, you know, obviously we've got somebody that's fallen off and they're complaining of severe pain in their lower back. So obviously you're going to make the scene safe. You're going to get somebody to grab the horse so it doesn't come running over you or the person that's on the floor. And you're going to try and keep them as still as possible. And you need to make that call. Now, again, I bang on and on and on and on about what 3 words, because a lot of the accidents that we have happen when we're hacking, or we're not necessarily in an area where it's very easy to explain where we are. I know we had a fire here and our address didn't exist when we phoned the fire brigade. So it's a problem then, especially when you're really stressed. So you would call the paramedics and let them know. And you want to give them as much information as possible, because obviously every time you phone an ambulance, you're triage based on the signs and symptoms that you have and what you tell the call handler. So if they can't feel their legs, or if they've been incontinent of urine, so if they've weed themselves, or if they've pooed themselves, or if they're that sort of thing, they need to know, and they need to get to you very quickly. Okay. So I will quite often see these injuries where there are fractures of the lower back, but on top of that, I can quite often see, particularly in equestrians, that they will come in with a fall, they'll end up with a trauma scan. They may end up with an injury or not an injury, but I'll say, so when did you fracture your T-spine, or when did you have your previous spinal fracture? And they'll be like, oh, I've never fractured my back. And I'll be like, well, yeah, you have. Definitely, because it's there on my scan. I can see that it's there. So it's not unusual for people to have, got sort of prangs in their back previously. And then pretty much most people will say, oh, I know what fall that was. So it is important that, you know, that you do come and obviously seek help. When it's a big accident, it's really clear when you're going to come to hospital. That's not the time where it's difficult. The difficulty is when you got up, you're okay, you're walking around a bit and things feel okay, but something's not quite right. It's making that decision about when to come. And what I advise in that situation is we're going to cover, as Maeve said, the cauda equina. So the real worry that happens with a back pain, and that pretty much translates over to trauma as well. So when we cover the red flags, that is exactly the same thing that is the worrying side from me. But then again, I see, as much as I see the more sort of exciting back pains, I see that, oh, I picked up a bag of feed and that's it, my back went, oh, my back's gone, that's it, you know, I've got a bad back. So I see a lot of that as well, and I'm sure you have in the past, Maeve, as well. Now, from my perspective, because I'm seeing them in A&E, it is a case of, is there any nerve involvement? So we will ask all the questions to make sure there's no nerve involvement. If there's no nerve involvement and no fracture, I'm going to send you home and I'm going to load you with as much pain relief as is necessary to get you moving and keep you moving, because I don't want you to go to bed. I'm going to refer you back to your GP, and if things don't settle down, your GP is going to be phoning up a very similar person to Maeve to say, can you take this young lady or young man on? So what are your thoughts on the kind of acute side, Maeve?
Yeah, so I mean, it's really common, first of all. So probably at least 80% of us will have some back pain at some stage in our lives. So the first thing is, don't panic. It's really quite normal. So yeah, we see a lot that maybe have bent over or lifted something that that has triggered an episode of back pain. And often they're just simple sprains and strains, like any other joint in our body or any other area in our body. You can sprain or strain that area. So, but it's just, I think, because when it's the back, we start to panic a bit. When it's your back, you start to panic a bit because, you know, you hear all the horrible stories. So it's pretty normal, and it's usually a simple thing, and it can be a sprain or a strain of any muscle in that area. There are plenty of joints in that area that can be sprained and strained, plenty of ligaments all around those vertebrae that can be sprained and strained, and they're not something that we necessarily can diagnose, nor do we need to diagnose, because they usually settle down themselves. So probably of that 80% of people who have low back pain, most of those will settle down usually within 4 to 6 weeks.
Now, I tend to explain it, Maeve. Now, I don't know if you'll tell me off now and I'll have to phone every patient I've ever seen. But I tend to say, you know, if I'd have broken, I've got wrong arm. Say if I'd broken this arm, my body would naturally make me hold my arm like this against my body to protect it. So I tend to explain it that when you twinge the back, you'll hate the word twinge as well, but when you do a twinge or whatever that you do, then the muscles all go into spasm. And
Absolutely.
So therefore it's the muscle spasm that causes the pain and the problem, because that initial little tweak of the nerve root or the disc has just bulged a bit and then gone back in. That's done. That's over. But you've got a spasm, and you've got to, and to be honest, that's why, you know, I'm very generous with diazepam, I'll be honest. If you've got back pain, come see me, because I'll load you up totally. But I find that
totally.
I mean, what do you think? Well, I hope you agree with me.
No, I totally agree with you. And often the muscle spasm is the worst pain, and it's what we would call adaptive pain. So your body's trying to protect itself, but sometimes that turns into what we would call maladaptive pain. So the body's trying to protect itself, but it's actually causing you more pain than it needs to. And so our brains are really designed to protect all the time. So if you get something like a twinge in your back for whatever reason, whether it's disc, ligament, joint, whatever, then yes, you get that muscle guarding and that muscle spasm, and that's often the worst bit. Or you get the people who come in because they're all bent over to one side because the muscles on one side have gone, I need to protect you, and gone hard at that. And then it's trying to settle that down and trying to keep people moving. So the most important thing, we want to reassure you that it's pretty normal, and it's not, if we've ruled out all these kind of red flags, these sinister things, and we've ruled out any nerve damage of any kind, then really we can do that with questioning, which is why when you come in, I'll ask you 50 million questions and you'll just want me to look at you and touch you. But actually the questions tell us so much more. And so it's looking at that, ruling out all of these more serious things, and then really just trying to reassure you that it's all pretty normal, and then everything will settle, but that we want to just keep you moving. So we don't recommend bed rest. We don't recommend anything like that. In first instances, things like heat and ice are fine. It's really whatever works for you. There's no set directive. Sometimes if it's nervy and you feel a little bit down your leg, then ice can be more helpful for some people. If it's pure muscle spasm, heat is often much more comfortable. Even things like hot showers, that kind of thing. Gentle movement. I'll try and put some exercises actually on my page this weekend of just really simple movement exercises for that really acute back, but it's just getting it to move. So gentle, like rolling of the knees or bringing one knee up to your chest when you're lying on your back, that kind of thing. And it's just, we want to calm things down. So it's all about calming down that nervous system and calming down that response.
Yeah, and it's very difficult. I mean, I've probably made light of the pain relief, but it's not unusual, you know, to see people that have come back and have got sort of chronic back pain, and then they come back again and they've had a sort of an exacerbation. So they've kind of twinged their back again, but they're already absolutely loaded up to the hilts with pain relief. So from my perspective, it's important that we load pain relief in the very beginning and then really hit hard with physio to try and get that back pain under control. Because then we can reduce the analgesia, because otherwise we don't have any painkillers for if it kind of tweaks again. And it's a really, really difficult situation to be in, because unless you've got any signs of the actual spinal cord being affected, we will not admit you to hospital. We just will not.
And nerves are highly sensitized structures. So even once, so say if there is a minor disc bulge that's put pressure on that nerve root, and so you get that horrible pain with it, when that pressure is taken off, and everything calms down, you still have a big inflammatory reaction around that nerve root, and then they're really highly sensitized. So the tiniest little thing can give you this massive response. And it's not that there's any damage, it's just that it's so hypersensitive that little things can trigger it off. So that's why we really want to calm everything down and then start to build things back up again.
Yeah, I mean, it's difficult, isn't it? I mean, do you think it's worth going over the red flags now so that people are aware of
them? I mean, these are the really sinister, serious things that we look for, and they're probably less than 1% of the population of people with back pain will have these, but they're certainly worth looking out for. So it's things like changes to your bladder and your bile. So any not being able to pass urine, or any loss of control of passing urine, same with your bile, any sexual dysfunction that comes with back pain. It's usually quite severe, unremitting pain down the legs on any loss of sensation. People might complain of really wobbly legs or loss of feeling in their legs. Those are the things that we might look into more.
Yeah.
And they're really, we're looking for the cauda equina is that big bundle of nerves that hangs down, and it's any pressure on that. So there can be the fractures like Diane talked about, or it can be a massive disc bulge, but it would be pretty severe. But that's why we question you on that. And so if someone comes in and they might have back pain and pain in one leg, but no other kind of symptoms, then I might just mention that to them so that they know what to look for without worrying you. But at least then you know and you have an idea, and that is an instant get yourself into A&E if you have any of these things. We need to get the pressure off that.
I covered it as well on the Medical Monday, because the thing with it is if you get one of those red flag symptoms, it doesn't mean that you've definitely got cauda equina. No. That's the thing.
And it's still really rare, but we want to check
rare, but we need to see it to absolutely make sure that you haven't. So, but if you have, then it's time critical, isn't it? That's the worry.
So.
Any damage and any sort of things that are happening to you then could become long-term or worse if we don't decompress that nerve as quickly as possible. And normally, it's surgery, it's spinal surgery that needs to be done. So you are scanned very quickly if your neurological examination shows that you need to be. because sometimes people can have quite severe pain down the leg, can't they? But actually the neurology, when it's very carefully examined in the hospital, is normal. And we run into a few issues with that, where the GP may say, go to A&E, they're gonna give you a scan. And then we're in a situation where we're saying to that patient, you know what, actually you don't need a scan, because we've tested all your nerves very carefully, and your nerves themselves are actually working and fine. So as Maeve said, you know, you do need to get yourself to A&E. I mean, that is without question. Those red flags, you've got to come, but it doesn't necessarily mean a scan, and it doesn't necessarily mean could require it. But we've got to make sure it's not, isn't it? Because
absolutely, and pain actually isn't the main indicating factor, and so you can have really, really severe pain with really hardly any damage, if that makes sense. So pain doesn't equal damage, which I did a post about the other day, but pain is protection. Pain is your brain saying, whoa, we need to protect this, and it's not indicative of what exactly is going on. And so these are really rare, but I think they're worth looking out for. The other thing that we maybe quiz people about is, which again is really rare, is cancer, a history of cancer, because you can have spinal metastases, and so we would look out for that. I think in my 20-year career I've picked that up once, so it is pretty rare, but it's something that we need to be aware of. And so they maybe present with a band of pain often, and it's quite severe, and they might have weight loss with that. They usually have a history of cancer. They might have very severe night pain, not in that a pain wakes you up when you roll over, but just unable to sleep, unable to lie down, and we would maybe want to investigate that further.
And that again is there to present as the primary, you know, the primary trigger that gets us to diagnose a cancer. That's normally somebody that, say, for example, has got a known prostate cancer, and then they come with the back pain. So, you know, we're not meaning to sort of worry you, but it is important that if these things are coming and you get those red flags, you need to come and see somebody as soon as possible. So what would you say? See, I think I see the most. I think the most I see, obviously trauma, parking trauma to one side. And the most I probably see is sciatica, and then just a simple sprain. To be honest.
So probably the most common is simple sprains and strains. So anything that goes along with that. And then probably after that, more acutely, I might see disc bulges. So the discs, and they are really strong structures, and they don't slip. Now, I don't like that terminology, because that really that gives you that picture that they pop right out of place. They don't. They're pretty strong, and they're really bound in to each vertebra by ligaments, so they can be pain sensitive themselves, but also they have a softer material, and it's not, sometimes people liken it to a jelly donut. It's not, because that gives you the idea that the jam's going to scoot out. So in the inside,
gristly, isn't it? It's gristly,
it's
like hard.
Like crab meat, kind of like crab meat. It's a bit tougher than that, but sometimes the disc can bulge a little bit, and that can press on these nerve roots, and that can give you some pain. And often then that pressure's taken off, but you get left with this inflamed nerve root, which will give you the pain down the leg. Sometimes some of that material can herniate out, so it actually comes out. But again, that doesn't necessarily mean that you need to have surgery. In fact, very rarely will you need to have, because our body's brilliant at adapting to cope with this. And so often what happens is that material that leaks out is reabsorbed by our body and taken away, but the pain that we're left with is this inflammation around the nerve roots, and they're really sensitive, and they can stay really
quite a long time to settle down, doesn't it? I think it's having that expectation and setting that expectation about how long something's going to take to get better.
Absolutely.
And I also again say with the soft tissue injuries, say like, you know, say the soft tissue injuries of ankle, for example, or whatever, I'll always say to someone, do you know what, actually I'm really sorry that it's not broken, because if it was broken, we'd chuck it in a cast, everyone would be really sympathetic, we'd put you on crutches, no one would make you walk, and everyone would say poor you. But you know what, that is going to take the same amount of time, if not longer, because you
usually so soft tissue usually takes a bit longer, and it's to do with blood supply and nutrition and things like that, but it can often take longer. And nerves are not necessarily not usually damaged in any way, because we can tell by doing tests if they're damaged, but they're so sensitive that little things just get you this massive reaction when actually there's no damage there.
I mean, is there anything, so that everyone's really clear? So we've said for the acute pain that keep moving, haven't we? You've got to keep moving, hot or cold, decent amount of pain relief in the initial stages. But you've got to try and reduce. So from my perspective, I would say, I don't know what you agree. I mean, I've had it once. So have you had proper back pain yet? Yeah. So I had it once after having a lot of knee surgery. I stood up, sneezed, and then I am very sympathetic to the back pain, never been in so much pain in your life. And I think that's something we would both acknowledge, having had it. It is incredibly painful.
Absolutely.
We're not here saying it's not painful. It's awful. And when you've got chronic pain, it can really wear you down.
Absolutely. Massively.
Wears you down, because it's every single time that you move, everything you try and do, then you manage to do something, then you sit down for a bit, and then it's worse because you've almost got to kind of like unlock to get going again. So we've got a lot of sympathy, but there has to be a degree of kind of, once you've ruled out any neurological problem, you've got to kind of just crack on, and you've got to strengthen that spine, haven't you? You've got to strengthen those muscles up.
And at the start, what we would say is, usually bending can be an aggravating position. So we might get people to avoid bending for a short time, just to calm everything down. But I would start them with some gentle bending exercises. So you're kind of almost tricking your brain to bypass that, because every time they go to bend forward, their brain goes, whoa, stop, and they get very severe back pain. So we might do things like lying on your back, bending the knees into your chest. That's a form of spinal flexion. But and controlled. It's a controlled spinal flexion, isn't it? Yeah.
And
so then I might get them to do a bit in sitting. So even sitting, bringing their knee up to put their socks and shoes on rather than bending forward. But it's still spinal flexion, and our spine needs that movement. It needs that flexion, extension, and rotation to give nutrition to the disc. So it's really important, and you can't avoid spinal flexion. So we need to prepare people for that, because that's often the thing that they report is the trigger for it. So the people who have this recurrent episodes of back pain where, say, they bent to pick a pen up off the floor and their back went, then it's usually because of the flexion. But sometimes we forget that there are other factors involved.
Okay.
So I might quiz people a bit about the physical things they did in the last couple of days, but often there are other issues that feed into that we maybe don't think about as much. And so things like how stressed they are can have an effect. Things like their sleep. So say if they've been having a bad week of not sleeping very well, that can feed into this. Nutrition, if they've been eating really badly, that kind of thing. And so it's not, people sometimes think, oh, but then, you tell me about these things, you think I'm making it up. It's not actually, because if we think of inflammation in the body, then all of these factors feed into that and can give you inflammation in your body. And also, if we think about patients that maybe have had strokes or heart attacks, when we rehab them or whatever interventions, we always speak to them about stress. We always speak to them about sleep. We always speak to them about exercise, and we always speak to them about nutrition, because they affect your physical well-being as well as your mental well-being. And so maybe these, when we have recurrent back pains, then we need to look into those other factors that have been involved in a couple of days.
It's the car theory. See, I use this at times to try and explain it, is that like your body's a car, but we kind of, I'm a bit like Boris, aren't I, with my little analogies. Oh, no, it wasn't Boris, it was Chris Whitty, wasn't it? But your body's a car, but the thing is with the car is we invented it, so we know exactly how it works, didn't we? But if you have a car and you're going to keep a car that you've bought from new and you're going to keep it going for 70, 80 years, my God, you've got to look after it. So not only have you got to put the correct fuel in it, because it can't drive without the fuel, like you've got to oil it up. You've got to, do those MOTs, that servicing, all that stuff. And hands up, I don't. I'm on a bit of a health kick at the moment, but I don't. And I do now with my bungee, but I didn't. I think I didn't before, mainly because of pain. So what would you say about kind of like the exercising with pain?
With pain, yeah. So, I mean, if
that can limit people, can't it? And then they can't exercise, and then they put weight on because they can't exercise, and then it makes the pain worse. And it's a very difficult situation.
It's a really tricky situation. And so we maybe don't look so much at the pain, but we look more at the function. So we'll maybe people with more chronic back pain, we might look into what they want to achieve and goals they want to achieve, and then we'll maybe get them to exercise so that, say, 10 out of 10 pain is the worst pain that you can possibly imagine, like not being able to move pain. So maybe we can get them doing a bit which takes them to 3 out of 10, and then I would get them to monitor that the next day. Does that flare you up? No, that's okay. So we keep doing that. And so sometimes, if particularly in really chronic pain conditions, I might get them to journal a bit. So they maybe keep an eye on what things aggravate it and what they can achieve. And sometimes that's nice to have a look back, because if your only goal is to be pain-free, then after 6 months you'll be like, well, I still have pain. But if you looked back over that 6 months, you might find that the function is much better. The pain sensitivity has reduced. Your pain tolerance is better. There might be other things that have improved. Your muscle endurance is better. You can do more. You can walk for longer. You're more, getting to where you want to achieve. So we'll maybe look at it like that rather than being pain-free being the main goal.
Really helpful, because I think the other thing is, I mean, I don't know the sort of age of people watching, but I'm in my 40s now, and it's still coming as a bit of a shock that something that I would have gone, oh, that's absolutely fine. I'd be absolutely fine with that. Because I am a crack on type of person, as most equestrians are. And then it's like, well, actually, that really bloody hurts. And it hurts for a long time. And it takes a long, long time to, and just with the boredom of the lockdown, I was looking at some videos the other day, and I was like, in this whole thing, feeling like I hadn't really got anywhere, having rehabbing with quite extensive injuries. And actually, if I look back to then, even now, but I've not looked back with that kind of mindset that I'm looking back at the particular leg to see the position of it. Whereas now, if I look at the position of my riding, I'm still not a Grand Prix rider, unfortunately. Your bungee's not done that, Maeve. But so I want my money back. But I can really see a difference. But it takes time, and I think that for me is a big thing, that it takes time to get better. And I think I think you guys are better at this, but I think as doctors, I don't think we're good at setting expectations. I mean, I'm talking from an emergency medicine point of view, because we're going to see you once because it's 3 o'clock in the morning and you can't cope, and we're not going to carry on seeing you or arrange you physio or anything else. So I wouldn't want to speak for the GPs, because I'm sure they're doing a great job, but I don't think we're, hands up, I don't think we're massively sympathetic. I think we know we can't admit you because orthopedics won't touch you unless you've got neurology. So it's a case of,
and to be fair, you don't really want them to. So really, from my point of view, spinal surgery is not a last resort, but you're pretty far down the line before you want to. You really, it comes with its own risks. It comes with a very long rehab. And when we look at research that's compared people with, like, 2 people with acute back pain with maybe a similar type MRI, and yes, maybe if they're in very severe pain, the surgery might reduce that a little bit initially. But if you look at them at a year, they're at pretty much the same place. And the other thing with spinal surgery is that often it leads on to more spinal surgery. And so that can lead you down a chronic path. And so we really, personally, from my point of view, I want to try and avoid it unless it's really necessary, like those cauda equina symptoms. Then we have a choice that there is no other option. But and
I think that's another point that I think we don't really say as doctors. I think from my experience anecdotally, the younger you are for orthopedic surgery, the more painful it is, because there's a lot of healthy, bulky tissue and stuff to go through. You're not 90 with no subcutaneous fat and no muscle.
And there's
density.
a longer rehab because you want to get back to a higher function.
Yeah, exactly. Because your function wants to be so much better, doesn't it?
And the other thing that we need to be really aware of, so a lot of people will come in and they'll want an x-ray or a scan, but we need to be aware of what is normal findings. And so there's a huge study done, I think it was in 2015, where they scanned about 3,000 people with no back pain. And they were all ages, so from 20 up to 90. And so they found massive variations and huge findings. And these people didn't have any back pain, nor had no major episodes of back pain. And so we talk a lot about, which is, I hate the word, but degenerative disc disease, because actually degenerative disc disease is normal. It's just normal changes in your discs as you get older. It's a bit like, I'm in my 40s, I've got wrinkles. We're all going to get grey hair. This is what happens on the inside as well. But if you read out a scan report to somebody and it says degenerative disc disease, of course they're going to go, oh my God.
My God, that's it. I'm done. I'll not be walking.
But in this study, they found 37% of 20-year-olds had some evidence of degeneration in their discs without back pain. So they're in their 20s, and then it was hugely higher. It was like 80. I've written some of them down. 80% of 50-year-olds and 96% of 80-year-olds. So it is something that happens as we get older. And then with disc bulges, what they found was 30% of 20-year-olds with no back pain had disc bulges. 60% of 50-year-olds and 84% of 80-year-olds who all had disc bulges but without back pain. And so that's why it's not financially that we don't want you to have a scan, and it isn't. And people often think, oh, we're trying to save money. We're not, because if you have back pain and you get a scan result and it reads out like that, instantly you have a panic. Anybody would. And so then you avoid doing things, you avoid movements, because you think, oh, if I bend too much or if I do this, it's gonna do something bad.
And strong, doesn't it?
And that actually makes you worse. Absolutely. And your spine needs movement, and fear of movement, what we call fear avoidance, is actually often worse for us than just moving.
I mean, I guess the only thing that I would add in with that is that if somebody, so normally some of the fractures that we see are the kind of compression fractures, which again I've kind of covered in the Medical Mondays, but you can get the ones where they kind of get a little bit squashed, or the height drops just from like a wedge fracture type thing. Sometimes if it's something that we think, oh, it wasn't really much trauma and you've got a fair old fracture for that, then it may be that you've got a condition that's affecting the way that your bone or how strong your bone is, and that you may need to go on to something called a Dexa Scan. And we certainly do that. So within our trauma service, when we go around in the week, we're very, very careful that you're looking at how old you are, what fracture did you get with the mechanism of injury that you had, which is again why I bang on again about, like, please tell us the proper mechanism of injury, because do you know what, if you just tripped and then you ended up with like a flail and all these transverse process fractures and everything else, maybe you've got a bone metabolism disorder that we are not something for if we aren't getting that information across. So it's an absolute minefield, isn't it? Really, a minefield. Now, I am very, very aware that our comments are
flooding in.
So
before we go to questions, I just want to run through some myths, because there's a lot of myths around back pain, and I think while we're here, we should do it. So first one, which we've talked about already. So your pain does not equal damage. So your pain is protection. So the more pain you have doesn't mean that there's more damage there. So that's the first one. Discs don't slip, which I covered that as well. So you can have disc bulges, you can have herniation of that material on the inside, which is often reabsorbed, and a lot of the studies find that often resolves itself, but they don't slip. Posture. So your back pain is not caused by bad posture. And so there's really no such thing as bad posture. There are just different postures. And the best thing that you can do is keep moving. Spines love movement. That's how they adapt. That's how they modify. That's how they get nutrition, that kind of thing. So don't freak out. Slumping at your desk all day will make you sore, but sitting up rigid at your desk all day will also make you sore. You got to move. Core stability. So your spine, your back isn't sore because your core is unstable. And I hate that term with a passion.
Love the core now.
It drives me nuts, this core stability, because that implies that your back isn't stable. Your back is so strong, so stable. They should just get rid of that term altogether. There are no better exercises for back pain than others. There's no bad exercise for back pain. There's no brilliant, life-changing exercise for back pain. Exercise is good for back pain. It's finding what you like, what you enjoy, and what you can manage at that point, what you can tolerate at that point, and then build up. And so
consistency, isn't it? Even if you can't do very much, do a little bit and then do the same the next day, even if it's only a couple.
Absolutely.
My mum had really nasty back pain, sciatica, and she actually did do it religiously, but she was on her bed, moving her legs and stuff, and and it was tiny amounts, but it's like, it's okay, you've done it 5 times, just do it 6 times tomorrow. And
and it'll all improve, but just finding what suits you at that point, at that stage. But and then finding something that you can do. I mean, it's recommended that we do 150 minutes of exercise a week. That increases our heart rate. So it can be whatever you want. It doesn't matter. Whatever you enjoy, because if you enjoy,
a long time, Maeve.
Yeah, it is. It's quite a lot, but that's what they recommend. So, but that can be schooling your horse. That's going to increase your heart rate.
Yeah, probably mucking out.
Yeah, that's fine. But it's finding something that you enjoy, because you're much more likely to stick to it. And so all the studies that they looked at exercise, the right exercise for back pain, there was none. And it was really that it's the physical act of doing the exercise that helps your back, rather than the exercise itself, if that makes sense.
Yeah, no, absolutely.
The other, we've talked about whether you need a scan or an x-ray. No, not usually. And there was a big study in your British Medical Journal this month, I think, about 95% of back pain doesn't need to be scanned or x-rayed. Lift, how you lift, that's the other thing. Oh, I need to lift and keep my back straight. No, you don't, because no matter how hard you try, you're going to get about 40 degrees of lumbar flexion by keeping your back straight. You're probably just going to make it more awkward for yourself. And the other thing of trying to lift, keeping your knees over your toes and not flexing your back. I mean, you couldn't lift anything like that. And so it's more likely that the load that you lifted exceeded the capacity that you can cope with at the time. And so it's improving that capacity of your body to cope with load rather than changing your technique. And back pain is for life is another myth that you hear. Oh, if you have a bad back, my back's really bad. You have a sore back at this point of your life. It doesn't mean that you're going to have a bad back forever. And so don't think of it like that. Think of this as an episode of back pain. I can get through this. I can get better. And then if it happens again, I can deal with it because I know what it was. Yeah. And so the scary signs and symptoms we've talked about, they're the ones to watch out for. Everything else, it's just about managing yourself through that stage. The avoiding activity or moving carefully because you might hurt your back, don't, because you actually end up making yourself feel worse because of it. Just move normally, thoughtless, fearless movement, breathing. I go on about it all the time. Belly breathing rather than holding your breath and bracing your abdominals. It's not good. Just breathe into your belly. And then we talked about the surgery. So they were the main things that I wanted to kind of get through.
No, and that's really important. And I guess the only thing that we would say, again, I know we're saying that, I just really want to reinforce as well, and I know Maeve does as well, that, it's very difficult when you come to us and you feel like we don't believe you. We do believe you. We do really, really
100% we believe you.
But
that's the frustrating thing sometimes with people that come and they've loads of pain and they've nothing on, they've had a scan and there's nothing on the scan. They're like, we believe you. Pain isn't fair. It affects everybody differently. It doesn't correlate with what we find. It's not fair to people. So we totally believe you. It's trying to get you to manage that then.
Yeah, and it's like, although we can kind of say, okay, your scan is normal, that does not mean that we're dismissing how you feel. It's just that we are there to give you some techniques to get going again. So we're focusing on that. So I do myself try hard to say, oh, I'm really sorry because you must be in so much pain, because it does make a difference. You acknowledge it. But I know a lot of people don't. So let's have a little look. Now I can see that we've got our little people. I hope nobody clicked on those links that are not supposed to be there. Okay. Yes, I have. I think we have had a little bit of trolling, but thank you very much for everybody for just ignoring and reporting and blocking. That's grand. Thanks a million. Unfortunately, that's just one of those things when you're doing lives. I'm just going down because they put quite a few on. Okay, so Rue says she's had 2 prolapsed discs in her lower back for over 20 years. And as a result, she's also had some fusion in that area. I'm not sure if she's asking a question, though. So Kate's had L5, L1 fused. Again, since then, the back has been better. That's good. But sometimes when riding and sitting deep in the saddle or flexing back is a big no-go area. So that would be strengthening up around it, surely, do you think, Maeve?
Totally. So that would be all to do with being able to... So your muscles being strong but supple enough to absorb the movement on the horse. And so a lot of the time we get pain when we ride because we're not absorbing, we're trying to brace against it, and then they just can't cope for a long period. So that would be a strength issue. Yeah.
So you can strengthen even though you've been fused.
Oh,
you can still strengthen.
And your body is so highly adaptable. That's the brilliant. That's why I'm not a fan of likening us to cars, because we are much more adaptable than cars. We can change. Our body can change, and it copes with things, and it adapts to cope with things. So we are highly adaptable.
Yeah. We've got a couple of people that I'm really bad at saying this. It doesn't help that I'm dyslexic, does it? But Sean has got spondylolisthesis, which causes
spondylolisthesis. Yeah. So that's basically it usually can come from a stress fracture, or sometimes it can be hereditary, but it's damage to this pars articularis. So it's when one vertebra might slip forward slightly. Yeah. And so it's still the same rehab would apply. You would still don't brace, don't get overly focused on transversus abdominis and all that stuff. Just gentle movement, what you can cope with, and then build up that strength. And so muscles like to move and get strong. Bones and discs need a little bit of load added. So you might need to hook up with a personal trainer that understands a bit about back pain or something like that. So you get a nice program that fits to progress you through that.
But I think Angela's popped a comment on saying she had 2 prolapsed discs, L4 and 5, and still has chronic pain since surgery in 2009. She's been left with taking tramadol, naproxen, Oromorph, amitriptyline, and a stomach tablet. And I think, bless her, I really feel for her, because she will still be in pain, but what she needs is a sort of graduated program. I think the thing I would want to say to her, and I'm pretty sure you're going to say the same, is it can get better. That's the thing. It can get better, but it's about getting you the right program.
Yeah. And sometimes when it's been
off,
and when it's been such a long time and your body is highly sensitized to everything, then sometimes it's about maybe not focusing on pain being the number one goal, but function being the goal, and whatever it is you want to achieve. And then maybe because we're trying to achieve that better function goal, then less pain is a byproduct of that. And then it's, more achievable goals, I think. But when you've been in pain for such a long time, that's really hard to manage. And so I think finding a physio or an osteopath or a chiropractor, I don't mind which, as long as they're working with you, and it's not about people doing things to you, because that's not going to give you long-term benefit. It's about people working with you, and you enter in a partnership with that therapist, someone that you trust and that you believe in, and that setting small goals to achieve bigger goals.
Yeah,
but
because it does tiny little steps will make a difference and add up over time. And that was really reinforced with me, because my position riding after my surgery was just horrific. And the difference, even though I felt like I was almost looking back a bit like, poor me, I've not been down, and I've not ridden this horse, and I've done that. And then actually what I came away with was, do you know what? It may have taken a long time, but you know what? I look completely different now. So it was quite a positive thing. So Tanya says, if you're having weekly physio, but it's not getting better, she's talking a couple of months. What's the next step? I think it'll take more than a couple of months, but Maeve, you
need to have a physio or a therapist that is working with you, not to you. So if you're having weekly physio and they're just doing stuff to you, and you're not getting stuff to do yourself, and you're not progressing through that, then I might look elsewhere, to be honest, because it should be a partnership. You have to enter into that partnership as well. But it's more about educating you and reassuring you and giving you things to do. I do manual therapy. I'm very hands-on when I treat my patients, but I'm hands-on to try and desensitize the tissues to show them what they can achieve, but I don't just do that. And so it's really important, particularly if you've had it for a long time, that you are achieving things and you are doing stuff at home, and they are giving you some kind of progression to work towards. And if they're not, I personally would think about changing who you're seeing. If you've been going for a long time and you don't feel that it's making an impact.
Yeah, I mean, it's the same as you do with a riding instructor. If you're just not getting anywhere, sometimes it's, you know, that it's worked for a period of time, but it's time to move on.
Yeah, and you have to put in the effort as well. I mean, I am pretty harsh with my patients. I won't see them if I don't think that they're doing what I've asked them. You know, what goals we set. Then I'll just say, well, I'm not treating you until you start doing that. Yeah, because it has to be a partnership. It can't just be a person doing stuff to you.
Yeah, and I think there is a part that is like, you can't go. I mean, I've had extensive physiotherapy, and I was very, very lucky to be treated by the sports team at the Robert Jones. So it's a specialist orthopedic hospital. So I was very lucky to have that opportunity. But I would say as well, you know, be very clear about what it is you want to do, because you know, they're trying to get you to a point of X and Y, but if you don't tell them what your X and Y is, and I had a lot of people say to me, oh, well, you only got that because you were a doctor. Well, no, I don't agree with that. I think it's because I said, for me, this is what I need to be able to do to fulfill my life and get my life back to normal. And so we need to work to that. And I think, like you're saying, don't let somebody do things to you. Take control. It's your body. You don't have to be bossy and horrible to anybody. You can say, I am involved in setting my plan, and by owning that a bit more, then you probably
100%,
more better,
definitely.
because it's hard, and it's
really
hard,
particularly if it's chronic things. Yeah.
Because when it's slow, it's just like, really, you just want me to bend my leg like 10 times a day? Come on, like, I want to get better. So, you know, it's a difficult one, isn't it? Oh, this is interesting. So Jane says, hello, she's had chronic pain condition, which she's had for 25 years. She's had plenty of doctors advise her not to ride. But in fact, I think riding does help keep me mobile and active. And because I enjoy it enough to cope with the pain. 100% from me.
Totally. And it's mind-blowing that if you enjoy something, that you will find ways to cope with that. And our bodies are adaptable. So
yeah, absolutely.
That's great. That's really positive.
So Claire's just started your program, which is great. There's a couple of people with Sherman's disease and sciatica, and what exercises they can do. I think you said you're going to pop something on it.
I'll pop some things on for basically acute low back pain. I think if you have a specific condition, there's no harm in going and getting it checked out by a physio if you're worried about things.
So Rue says she's let herself get very stiff and one-sided and need to address it now. I'm 49 and I don't know if I'm only going to get worse. I have less mobility in my lower back due to the fusion, but really aware I need to sort myself out. See, to me, I mean, we're not doing this to sell a load of stuff or anything, but I would say for me, for me, using the bungee program, I've still got significant issues. You can control it quite well, and you can control how much you kind of put through yourself. But you can definitely, if I can go with nerve defects as well to where I am now, it can be done.
Yeah. I don't advertise my program for pain relief, so no. I'm very ethical. I don't think anybody should, because it's very different, it's very individual. But I do get a lot of reviews and a lot of comments that as a side effect of doing my program, their pain improves, and so I think that's fabulous. But I don't advertise it as this will help your low back pain, because I can't guarantee that.
No.
But exercising will, and if you can find something that you enjoy, that helps. If you can find something that's evidence-based, so you want strengthening, you want movement patterns that are appropriate for that, then that helps too. And
I think, like you say, having that mental, that just something that's actually satisfying, it can make such a difference, can't it? It really can. Let's have a look now. So Jenny broke T4 in September, fell off in cancer. Took ages for the two bones to seal together, and now she's been told she's got osteoarthritis. So osteoarthritis wouldn't have occurred that quickly. It's just that if you have any damage anywhere, you're more likely to get it later on. By the end of the day, she ends up in bed and she's in so much pain, bless her. Is there anything more she can do?
Again, probably you're not that far down the line. If it was only, what did she say, September? You're not that far down the line, so don't lose optimism yet. It probably will get a lot better.
Yeah, she's only 5 months. She's only 5 months.
Not far down the line. I would find somebody to work with and find an exercise program that just T4 is higher up, so you want lots of mobility in that area, particularly rotation. But yeah, I think find somebody to work with that will give you a program to work with.
I honestly, I promise you, Fish fell off his bike on the Great Orne, had I think T4, T5 fractures. It took a long time, but he's back doing
a long time.
Yeah. It took 18 months, but he's back doing it. He still gets a few bits and pieces, but you can do it, because I've seen him do it. So Becky says, oh, that's fine. Oh, bless her. So Becky had herniated discs. Had some surgery which caused a large bleed and a hematoma, which gave her cauda-equina syndrome. She's been left with cauda-equina syndrome plus to have discs out again. I mean, it's still going to be the same thing, isn't it? She's going to need to strengthen up. I mean, obviously, if there's anything where there's any acute compression, that would need to be relieved.
Yeah, so it depends on what symptoms that cauda-equina has left you with, basically. But I would still try and improve function, so movement, strength, control, that kind of thing. But yeah, it would depend on that. Sounds awful, poor thing.
No, bless her. Debbie, I know Debbie actually. She had really not. I'm not quite sure how you did it, Debbie. I've got to be honest, I can't remember. But she broke her back, and then she's just had really struggled with her with one of her legs after that. So, and then they wanted to fuse her spine about 25 years ago. But the outcome wasn't very successful for surgery at that point, so they didn't. So she's used the TT technique, the best thing she's done in riding to keep it all moving. So I mean, it's a very common theme, isn't it? It's about strengthening. A lot of people are saying that they've really found that sleeping with a pillow between their legs help at night. I do that
definitely for acute, particularly acute pain, or one of those big pregnancy pillows sometimes can help as well, because it just reduces the rotation that you're putting through your back. Or if you want to lie on your back, then having a pillow underneath your knees just changes the position of your back, particularly for those acute phases.
Amy says, can you be a bit more specific about nutrition needs during an inflammatory phase?
Well, it's just good nutrition. And I'm not a nutritionist, but basic good nutrition, so that you're through that inflammatory stage. And exercise is really anti-inflammatory, so finding something that helps with that.
Oh, bless her. So Jules, 9 weeks post L1, 2, 3, 4 fractures.
Ooh.
So, ow. Sent home with codeine and rest from A&E. So I suspect maybe transverse process or something, or spinous process. I was told that menopause may have meant my bones were weaker. Very true. And only now well enough to start light exercise.
Yeah.
It's the which is hard to take as I couldn't exercise. Oh, and HR.
You're really early days.
So early. Yeah.
Don't panic.
Don't panic. You'll get there.
Stick to what they've advised and build it up nice and slowly. You're really early days. You have loads of time to get better.
So Lynn's saying we keep referring to a bungee. What is it?
I haven't actually got one.
So mine's in the house. So it's Maeve's at Maeve.
I can grab 2 seconds. I'll grab one.
Yeah, let Maeve grab one. So this is how I actually met Maeve, because she had devised a sort of exercise program that uses I'll show you now, a kind of bungee where you can go against the resistance when you do the exercises. So when you're doing stuff more than just doing it, and then you get access to the exercises as well. And that's how we met, because I started using her program and fell in love with us.
So this is the bungee. So it's basically resistance. And so it attaches into any door frame. You put this through your door, you close the door onto it. This bit goes around your pelvis, and then you're working against pretty decent resistance. And the further you move away from the door, the more resistance. So you can progress it in that way. And then it's just a series of exercises that I've developed that help target all the muscles around your pelvis and hips. So it's designed for horse riders, basically.
Yeah, no, honestly, it's worked for me. But you put a lot of stuff on your page, on your Instagram and your Facebook, don't you? Which are exercises that you can do that, you don't need to go and.
You don't necessarily need the bungee. So I do some with the bungee and some without. I hope the page is educational and interesting.
Yeah, no, it's massively good, your page. I love your page. Even Fish uses your exercises as well. That's the thing. Like, you can take it that step further, can't you?
Yeah.
Or you can, if you want to just do the stuff that you put on there for free, then that's absolutely fine. So is turmeric, can't say it either. Is it anti-inflammatory? Well, it's all very trendy, turmeric now, isn't it?
Very trendy, isn't it? I mean, yes, possibly. Really, when I talked about inflammation, I meant low-grade inflammation with any kind of so stress will feed into probably the biggest factors are stress, not sleeping terribly well, and not moving, inactivity. So they're the things that you can really change. Yes, if you want to add things into your diet that are anti-inflammatory, that's fine. But I wouldn't do that and not look at the other things.
No, because you've got to you've got to work on the strengthening as well, haven't you? Debbie just wanted to say that she wants to say to everyone that there is light at the end of the tunnel, and she went from constant pain to now occasional pain, and she's back to full riding with just some instability at times in her lower leg. Now, I saw Debbie ride at a camp just after she'd had some surgery. She was quite soon post-op, and she was so brave just to do it anyway. And you could tell that she was, she was in pain, and she still did it, and she did so well. And then I've kind of followed her on Facebook, and she's back. You could see her progress over time, and it is. I think that's the biggest message, isn't it? That things do get better.
They do.
But
time is a big factor, and also finding things that you can do to help yourself, basically.
And it's just making sure, like you say, is taking, I guess, in a bit like motherly sense, you've got to take responsibility for your injury as well. I think I always try and set expectations in that with any injury, really, that we will try and get you back to the best function that you can have, but any injury will usually leave, some degree, may not with a back strain, but if you've had a fracture, you've had a fracture. So it's about giving your body time to adapt, because your spine takes the whole weight through, and that can maybe then your knee might start hurting because you've got
because you're compensating.
But you've got to give it time. You've got to give it time, and it does take time, and it's really, really hard work to rehab, isn't it?
Yeah,
hard
definitely.
work.
And you've got to put the work in, and nobody's going to wave a magic wand that's going to suddenly make it better. There's no magic treatment technique. It really is, there are some things that will help and calm things down, but you've got to build things back up again, and that's the important bit, the building things back up again once you're able to.
Okay, so last question, because we've kind of gone over the time, is from Marie. So Maeve, Marie has SI pain and needs to activate and strengthen her core. She has an acromial bone spur and a rotator cuff muscle tear, for which treatment is postponed during COVID. Can she do your exercises without the arms?
Yes, yeah. Level 1 has no arm involvement. And I did a post today about SI pain, but quite common in horse riders, this area here. Now, it doesn't move a lot, this joint. It's probably only got about 8 degrees of rotation, so it's not a highly mobile joint. It doesn't come out, and you don't need to put it back in. But muscle, there's huge muscles acting on it, all of the glutes at the back, and my favorite, psoas at the front. And so often what happens is that you've a lot going on at the back. Maybe this is a bit weak, and so I find a lot of riders, that's what I get a lot of feedback from, using the bungee. It helps strengthen this psoas, and that helps calm this down, and they end up fine. This is much better, and that's an issue that I have had, particularly after my first child, and it's made a massive difference for me.
That's what I get as well. But I can say, just to finish as well, like, we've got this kind of like love of psoas going on, haven't we? But I can honestly tell you, if you open up split a belly, open it up, get everything out, actually the only muscle really holding your top of your body to your bottom of your body is psoas, and it's on the inside, and it is so forgotten about, so underrated.
It's blamed to be tight all the time. That's all I ever hear. Oh, my hip flexors
it's not tight.
It's weak. So we need to strengthen it, and it's really important. I would focus much more on that than worrying about what transversus abdominis and all that's doing, because it's actually, when you dissect that out, it's not really that hugely important, but this is. And so don't worry so much about core, and I don't like that term particularly. Think of the muscles around the pelvis and the lower back, and psoas actually attaches on all these, comes from the front of all of these vertebrae, and that's where it attaches from, and it goes through and then into the hip. But people forget that it actually influences massively this area of your spine. Yeah.
So that's great. So thank you so much, Maeve, for coming on.
Problem. I could probably talk for days on low back.
Well, I think, as we say, we've covered pretty much every sort of main question that's come through here. But obviously, we are both on social media. So if you want to contact us, Maeve, you go into your activate your seat one, wouldn't you, for someone had a question?
Yeah.
So tell us everywhere that we can find you, Maeve, so for the people that don't follow.
Activate Your Seat on Facebook and on Instagram mainly, and I have a website which is Activate Your Seat, but probably Facebook or Instagram is the easiest way to and I have a lot of information on there. Hopefully you will find some of that useful anyway. Yeah, no, it's super useful. And obviously, as you know, this is the All the King's Horses Facebook page, and there is an All the King's Horses Instagram as well. So either DM through there. We're both working full time, both Maeve and myself. So, we don't always answer straight away, but we will get back to you as soon as we can. So thank you very, very much to Maeve for joining us, and thank you to you for joining us. And I hope that was helpful. And we will catch up with you again soon. Yes. Oh, and you can win a bungee. Don't forget that.
Oh, of course you can. Sorry, Maeve. Yes, there is a giveaway. So for anybody that hasn't got a bungee, and why not, there is a giveaway of a bungee. So all we want you to do is to follow both Maeve and myself, and then we will have a look and we will see who we think would benefit from it the most. And then we would love to give everybody one, but unfortunately, Maeve would go out of business. So, but I fully recommend it. So pop onto the page. I will share it to stories again, but pop onto the page, get your entry in. And I think we said we'd have a look at it this week, didn't we? So we're going to have a look around. So.
We'll check. We'll be on the post.
Yeah. So good luck, and we will catch up with you again very soon. Take care, guys. Oh, I've looked up N.